Ms. Irene Quay.
Mr. Deputy Speaker, sir, I declare my interest as the President of the Pharmaceutical Society of Singapore, Assistant Director of Allied Health Office at KK Women's and Children's Hospital, as well as the co-chair of the SingHealth Allied Health Executive Committee. I would like to impress upon the House two proposals regarding the upcoming Employment Bill amendments. Firstly, for the Ministry of Manpower and Ministry of Health to explore allowing registered collaborative practice prescribers who are running clinics in hospitals and polyclinics to issue medical certificates. I will refer to these practitioners as CPPs. Secondly, for MOM to consider working with the Tripartite Alliance and encourage employers to allow for up to 3 non-consecutive days of sick leave without MCs per year. I'm deeply concerned with the rising healthcare costs in Singapore and the expenditure on elderly healthcare. These are issues affecting our healthcare system and has been highlighted in the 2018 Singapore budget. With the increasing burden of an aging population, along with the surge in the incidence of chronic disease and complexity of chronic disease management, we need to focus on a team-based model of care where various healthcare professionals, doctors, pharmacists, nurses, allied health professionals come together and work in synergy to provide cost-effective care outcomes in line with the Ministry of Health's Beyond 2020 Master Plan. As such, there's a need for us to empower our allied health professionals, nurses and pharmacists to take on greater roles in the management of minor ailments and chronic disease management to provide value-based care at a sustainable cost and to actively look into ways to eliminate inefficiencies in our healthcare system. One such approach I would like to suggest is to allow practitioners under the recently approved CPP framework to be able to issue MCs. This framework came in operations on the 1st of March 2018 and certify a practitioner under the National Collaborative Prescribing Assessment Framework to be able to review and prescribe independently within the scope of their Collaborative Practice Agreement CPAs. This certification is done in a setting that requires the issue of MC, for example, in ambulatory care clinics. All CPPs have to undergo and pass a 3-month National Collaborative Prescribing Program. In each institution, a privileging and training framework is in place for CPP to see patients in a clinic. And practitioners must have at least 3 years of experience with at least a year of team-based care before enrolling in this National Collaborative Prescribing Program. CPPs are regularly reviewed by the Credentialing and Service Review Committee to ensure safety and appropriateness of care. They are also required to maintain a competency portfolio for re-credentialing. Nurses under the CPP framework are registered Advanced Practice Nurses APN who have completed the Master of Nursing program accredited by the Singapore Nursing Board SNB for APN training or its equivalent and has successfully completed a postgrad 1-year APN internship program. Likewise, CPP pharmacists are advanced practice pharmacists or specialist pharmacists registered with the Singapore Pharmacy Council SPC who have completed postgrad training or its equivalent and fulfill the compulsory continual professional education points for maintenance of licensure by SPC. So as you can see, practitioners under the CPP framework go through vigorous training, are constantly audited to ensure high standards of care are upheld, and are well equipped with the necessary industry certifications. Currently, these practitioners can only provide excuse sheets to patients, and if patients require MCs, they will have to be directed to the medical doctor where they will have to wait again for doctors to furnish their MCs. It causes unnecessary delay to patients and can be disruptive to both the CPP and the doctor. At the current moment, most employers accept MCs but not excuse sheets. The reasons I've stated above provided sufficient grounds for MOM and MOH to consider certifying CPP license to provide MCs to the general public. This brings me to my second point, which is for MOM to consider working with the Tripartite Alliance and encourage employers to allow up to 3 non-consecutive days of sick leave per year without MCs. I'm sure that everyone who works will have to obtain an MC when they are unwell at some point in time. And you may have woken up perhaps with a flu, feeling a bit feverish, and decided that you're not able to work that day. However, you will first have to get an MC. And that would mean going to the nearest private clinic or polyclinic, queuing up with other patients and risk spreading infection. Apart from being unproductive and potentially spreading your contagion, and being out and about will actually exacerbate your illness when you should be getting the much needed rest at home. One may even conveniently ask for unwarranted antibiotics since they are already at the clinic, contributing to global antimicrobial resistant problems. Allowing employees to take up to 3 non-consecutive days of sick leave per year without MCs will also display a strong signal of trust and partnership between employers and employees. It will also create better accountability and higher morale among staff because the system has shown them that their employers trust them. I understand that the current Employment Act is not prohibiting such practice, and in fact some healthcare clusters and civil service organizations have already implemented this practice for many years. But there's a need for MOM to mandate it in the Act so that these benefits can be accelerated across the nation rather than to let nature take its course. I understand that there will always be the perennial concern of employers how to prevent abuse of this system by employees who like to king. In response to that, I would like to propose creating controls such as audits and provision for the privilege to be withdrawn for employees who will abuse the system, and a surveillance system to be put in place to ensure that we do not miss out on cluster infections. In any organization, there will always be a small percentage of employees who will abuse the system. The benefit of allowing sick leave without MC will outweigh the small number of abuse cases. In fact, even with our current situation, it is not difficult to get a day off from work by faking an illness to get an MC. A survey conducted by online portal Job Central in 2012 reported that almost 20% of some 3,300 Singapore employees admitted to faking an illness to get away from work at some point in time. Should MOM and MOH choose to adopt my 2 suggestions, the benefits to patients and our healthcare system will be manifold. It will help organizations save on unnecessary medical claims from employees just to get MCs for simple viral infection or minor ailments. The right to issue MCs by CPP also elevates the recognition of the CPP's role. It is a necessary amendment to level up the CPP model to be in line with doctors. If implemented, necessary steps will be taken to refine the CPP model in line with industry standards to ensure appropriateness of care. This will lead to improved patient access to healthcare through right siting of patients and lead to healthcare cost containment in the long run. Doctors in the community can then be freed up to see more complex patients and be subvented appropriately based on the complexity of medical conditions seen as well as clinical indicators met. This privilege can later be considered for physiotherapists and occupational therapists to empower them as first triage point under the new rehab model of care. These are highly trained allied health specialists with postgraduate degrees and at least 3 years of work experience. Overseas studies have demonstrated that patients with musculoskeletal conditions such as non-severe back or neck pain, as well as hand injuries, benefited from early access to physiotherapy and occupational therapy at the primary care or emergency department. Locally, even if early access is available to these patients, they are required to visit the doctor for an MC. Mr. Deputy Speaker, in short, this proposal will reduce inefficiency in our current healthcare system, allowing for better patient experience and contain healthcare costs through the optimization of healthcare teams without compromising clinical care. As we move into the aging tsunami, there's an urgent need to proactively review our healthcare system and remove inefficiencies, making our processes leaner so that healthcare costs will not end up as a financial burden to our next generation. Notwithstanding my request stated above for MOM and MOH consideration in future Employment Act Bill amendments, I stand to support the bill. Thank you.